Good morning. Hello. Morning to everyone. Can you all hear clearly? Rehan, can you hear me?
Yeah, can.
Okay.
I think
Shall we
everyone
start?
else is muted. Can hear, can see clearly.
All right. Okay. So good morning, everyone. Whoever's in this meeting so far, I think we shall start now since it's 10 o'clock on a Saturday morning. Our esteemed speaker for today is a good friend of, and she has done a lot for the pathology fraternity, and she has just finished her fellowship and she's back after doing her soft tissue fellowship in Singapore. So let me introduce Dr. Noorjehan. And Dr. Jehan, she did her undergraduate medical degree in UKM, following which, after some work, she did her Masters of Pathology under UPM. And recently, she finished her fellowship in bone and soft tissue tumors in NUS, Singapore. Currently, she is back and serving our KKM in Hospital Serdang. So Dr. Jehan has moved around quite a bit in entire career from HKL, Hospital Serdang, Hospital Tengku Ampuan, and now she is based back in Hospital Serdang and taking bone and soft tissue cases as a special interest. She has also written many local and internationally published chapters and pages in journals as well as posters. So today, I think we're all looking forward to hearing from you, Jehan. So let's start and yeah.
Okay, thank you, Yavita, for the kind introduction. Okay, I'm Jehan from Hospital Serdang. Shall I start now? I think we have a number of participants already, right?
Yeah, I think there's quite a
few. We start now, okay? Wait, I share screen first. Okay, can see Yavita?
Can, clear. I think the share your screen.
Yeah, okay, I slideshow. All right, okay. I remove this panel first. I might not be able to see. Okay, so I have about 80 plus slide, Yavita. So around around 20-minute time I should reach in this slide. I should reach this. Oh no. I should reach. Yeah. Soft tissue synovial.
Right.
All right. So I'm going to remove the panel first. Okay. Yeah, I can see, right?
Can.
Okay, all right. Because I cannot see you anymore.
Okay. Can see your slides.
All right. Okay. Can see, right?
Can see your slide.
So, Assalamualaikum. Selamat pagi, everyone. So I'll be presenting IAPMD session for bone today. So I choose topic giant cell rich lesion, the overview and new concept of giant cell rich lesions. Because a lot of changes we have in giant cell rich lesion in the new WHO book. So that's why I choose this topic. It's going to be a large topic. So okay, this is the summary of the topics under giant cell rich lesion. Under giant cell rich lesion, we have bone. For bone lesion, we have the conventional giant cell tumor of bone, which can be further divided to intermediate and malignant type. And in malignant type, it can be further divided to conventional malignant type and non-conventional malignant type, including the undifferentiated type. And also under the bone, we have giant cell rich giant cell reparative granuloma, non-ossifying fibroma, brown tumor and the related lesion, not related but morphologically related, aneurysmal bone cyst, giant cell rich osteosarcoma, and chondroblastoma, and also other mimics soft tissue giant cell rich lesions such as the tenosynovial giant cell rich lesion, soft tissue giant cell rich lesion, and also other tumors like nodular fasciitis, myositis ossificans, dermatofibroma, benign fibrocystocytoma, and other fibrocystocytoma, pleomorphic hyalinizing angioathetic tumor, and the related hemosidrotic fibrolipomatous tumor, and phosphaturic mesenchymal tumor. Oh, yeah, can see it. Okay. Inflammatory leiomyosarcoma and giant cell rich UPS. So among all these, I choose the most relevant 10 topics, and I'm going to present in a way, in case presentation way. Okay, so for the first case, is a 32 years old female with below knee swelling. So this is her X-ray. So for bone lesion, we always must get the X-ray details, so that it is, because like for soft tissue will be like pattern. The pattern will be more important. For bone lesion, the X-ray will be very important. So for the X-ray finding for that patient is she got expansile a lytic lesion within her upper tibia, and this lesion have narrow transformation zone and is abutting the articular cartilage. And as you can see, the soap bubble-like appearance, and also some cortical break here. This tumor also causes thinning of cortex, making into eggshell appearance. So usually this kind of tumor, the lesion will be in epiphysis and eccentric, such as like this one, but this one already extended a bit. This is the morphology of her lesion. Low power view, we can see numerous giant cells, and the giant cells are big, and in the background there's mononuclear cells. Okay, this is the slightly higher power view. The giant cell have a lot of nucleus, more than 50, and in the background got a lot of mononuclear cells. Actually, there are a few types here. Some are the neoplastic cells, some are not. But actually, in giant cell tumor, it's very difficult to differentiate between the macrophages and the neoplastic cells. Last time we used to say that the mononuclear neoplastic cells have nuclei same like the giant cell, but I think now the concept already changed. So this is giant cell tumor of bone. I actually accidentally told the answer just now. Sorry. So giant cell tumor of the bone. It is a locally aggressive, rarely metastasizing neoplasm. 10% of cases are malignant. The peak incidence is in 20 to 45 years old in young adults to adult. The location is usually end of mature long bone. It's occasionally seen in immature skeleton arising in metaphysis, but sometimes can be seen in small bone, axial, and flat bone. Rarely it will be seen in craniofacial bones unless the patient have a Paget disease with concurrent giant cell tumor. Paget disease are usually associated with other sarcomas, including including conventional giant cell tumors. There's also cases of reported for laryngeal giant cell tumor. This one occurred in the thyroid cartilage that have undergone bone metaplasia. And usually if it involves vertebra, it will be from the body to the posterior element, but rarely it will be posterior element alone. If in posterior element alone, we must think of something else, such as ABC or others. So microscopically, this is the slightly higher power view. We have the component will be the same, giant cell tumor with mononuclear cell, same like other differential, but there's minor difference that can help you determine which one is which. So in the background, we've got mononuclear cell, which is the macrophages, and the neoplastic stromal cell, neoplastic mesenchymal cell. But in giant cell tumor, it's difficult to differentiate between those two unless you use stain. The clue is the giant cells are usually evenly distributed, and the giant cells are usually large, got a lot of nucleus, and the giant cells are usually a lot. The mononuclear cells have round to oval nuclei, and sometimes in region regressive tumors, the spindle cell will be more spindly in a fibrotic stroma. These are other morphological patterns. Sometimes have secondary APC changes. Sometimes will be like fibrous histiocytoma, the regressive type. So it will be more collagenous stroma, and the cell will be more spindle. And then sometimes if you have a corticular, if you have a fracture, you'll have some bone formation. I'm not sure this is bone formation. Maybe this is sclerotic bone only. And also in some cases where the stroma cell is hypoplastic, you'll also show giant cell depleted areas. We call it stroma overgrowth. Rarely you will show cartilage formation. Okay, this is the new thing in WHO, the identification of the molecular alteration in giant cell tumor. So 80% of giant cell tumor is have shown to show G34W mutation in the histone protein. So the histone 3.3, one of the amino acid being changed from usually from G to W, which is tryptophan to from glycine to tryptophan protein. But also can other type of mutation can also be seen, but this is much less. Usually it's G34W, about 80% of cases. Giant cell tumor are also associated with other syndromes such as pheochromocytoma paraganglioma syndrome, and also the common one is the Paget disease. This lesion will show different type of mutation, so you might not see the G34W mutation in other syndromes. So what happens is when there's mutation in the histone protein, it causes downregulation of the E to F, causing increased proliferation of the neoplastic mesenchymal cell, and this neoplastic mesenchymal cell have the ability to stimulate macrophages and giant cells using cytokines such as the rank. So these are articles about other mutation found in giant cell tumor. Most are about the Paget disease, the new mutation found ZNF687, causing giant cell tumors in Paget disease. Also, a few other mutation identified such as profilin 1 and also others. Okay, the identification of this mutant mutation has helped us in getting markers to identify giant cell tumor. So it's slightly easier now because there's marker to differentiate giant cell tumor of bone from other giant cell tumors. Giant cell of tumor of bone is very important to differentiate giant cell tumor of bone from other tumors, because this tumor can transform into malignant and is associated with very high recurrence, and sometimes can cause morbidity and mortality just because of the recurrence. So this new marker is shown to be very specific and very sensitive. 83% of cases will be positive. So if negative, it's very rare to be negative. If negative, most probably is other tumor or other type of mutation, which is less likely. And this marker also will be positive in malignant cases. So if you see a malignant case, but there's no conventional area to help you determine what type of tumor it is, you can, if the location is correct, age is correct, you can try G34W immunohistochemistry. If positive, it's most probably primary giant cell tumor, primary malignant giant cell tumor. So this is the immunostain. It stains nucleus. And to prove the point, this is the giant cell tumor, the osteoclast-like giant cell, and this is the neoplastic cell, and this is the macrophages. If you can see here, only the neoplastic cells are being stained. The osteoclastic cells are not stained, the macrophages are not stained. So they are of different type of cells. prognosis and treatment of giant cell tumor. Also because of the identification of the mutation, we are able to diagnose correctly and also offer treatment, especially in advanced cases, to reduce, induce surgical downstaging so that patient will be able to undergo limb sparing surgeries. This drug denosumab is the drug we're talking about. It's a human monoclonal antibody directed against rank ligand. Sorry, I have to take this. Aris, no, you have to call Papa. I'm in the meeting. Bye. Bye. Sorry, ladies, my son is in the school, so I have to take that. Denosumab is approved for treatment by FDA in 2013 for advanced giant cell tumor, and is very good for surgical downstaging. It is a cytostatic kind of treatment, not cytotoxic, meaning the stromal cell will still be there. You only inhibit the rank ligand to inhibit the tumor process, but the neoplastic stromal cell will be still there. So this is the image to show this. So this is a mesenchymal tumor cell, mutated mesenchymal cell, producing the cytokine rank ligand, stimulating the osteoclast-like giant cell and causing bone destruction. So with denosumab, it will inhibit this and stop bone destruction by osteoclast and promoting bone repair. So denosumab promotes tumor shrinkage and causes central sclerosis, peripheral bone formation, and causes complete healing of pathological fracture associated with pain relief, better function, and also mobility for patient. So giving denosumab causes a lot of morphological changes in the tumor, and this article really explained in detail with a lot of pictures on denosumab treated samples, and it is a very useful article. I think if we already start getting samples from denosumab treated giant cell tumor, we should refer to this article. So basically, I will show the picture later. This is just the list of it with the percentage of how common it is. So in X-ray changes, this is before treatment, the eggshell-like thinning, and then after treatment, it induces bone formation at the periphery, making tumor shrinkage, and also and also reducing destruction of the bone. So this is the image of the changes after denosumab treatment. First, the osteoclast will be much reduced. More of the mononuclear neoplastic cell only left here, and also the promote peripheral bone formation in form of bone rimming, in form of a shell of bone. And then for the mononuclear stromal cell, it become more fibrous, more spindly. Some area will be still cellular. Some area will appear epithelioid and a bit worrisome, but it's normal to see this in post-denosumab treatment. If you see this kind of morphology, just be sure that there's no atypical mitosis, there's no pleomorphism, then it's still okay to call it post-treatment sample. And some degenerative changes also can be seen as long as it's not in sheet, just focal or scattered, it's still okay, and as long as there's no atypical mitosis. This is the osteoid formation, because denosumab promote bone repair, so there'll be a lot of osteoid. Some osteoid will be immature, some will be in lace-like pattern, but you can see the contour is smooth and rimmed by single layer of osteoblasts. And some areas will be mineralized, some will be in paratrabeculae, and also can see cartilage formation. This one is not so frequent. This is the stromal changes. Among the stromal changes that you can see is fibrotic formation, hemangioparasitic like vessels, and also cyst formation. Sometimes you can see storiform stromal changes. Occasionally, you can see cystic spaces lined by osteoclasts. Okay, I don't think so. We have started denosumab in Malaysia. Maybe some center already start. Maybe I think Yavitas and Johor already start.
Yes, Johor has denosumab already.
Okay, so probably you will start receiving samples. So what other center that already start receiving samples from post-treatment experience is they experience problem with high recurrence. This is for clinician, high recurrence, and also they have problem with deciding what is the safe dose and duration, because some article claiming that there is malignant transformation after giving denosumab, and also some discussion about efficacy of denosumab in other giant cell rich lesions such as tenosynovial giant cell rich lesion. Actually, denosumab is a drug that was created for osteoporosis, then is used for giant cell tumor of bone. So probably would be useful also for other tumors that have same pathway of bone destruction. So and also about the malignant transformation, is still unclear whether or not denosumab caused malignant transformation, because there's issue with sample population. As we know, denosumab was only given to advanced giant cell tumor. So it's maybe it's just a natural cause of transformation, even though without giving denosumab, because the incidence in denosumab treated patient is only 1%, about the same with non-treated patient. And also there's an issue with biopsy error. Maybe it didn't sample the initial malignant areas, and also because of the histological mimics, because post denosumab samples can really mimic osteosarcoma and malignant giant cell morphology. This article discuss in detail about the problems in denosumab treated samples and denosumab treated patients. Okay, about the recurrence after denosumab, it is shown that local recurrence is associated with possible. It's shown that the local recurrence. Sorry, this is different article. In this article, they have shown that there is local recurrence after giving denosumab. So, sorry.
Dengar tak? No, you're 25 minutes already.
Oh my God. Okay, I'm very slow already. I think this one just want to show you that even though after giving denosumab, the neoplastic stromal cell is still there. So you have a bone shell, right, after giving denosumab. So this stromal cell is still entrapped there, causing the higher tumor, the higher local recurrence. Okay, and malignant transformation basically is just saying, this article just explaining that it probably is a misdiagnosis, because it happened very early on, even earlier than post radiotherapy samples. So probably it's actually already malignant initially before starting treatment. So and also this article by Jason Honig and et al. Also discuss about how the post denosumab treated sample will mimic osteosarcoma. This from Tariq just now. The changes in denosumab treated samples can mimic a lot of tumor, fibrous dysplasia, NOF, low grade osteosarcoma, and also high grade osteosarcoma. But it's actually not. You have to see the mitosis and also other changes. Okay. This is malignant transformation in conventional giant cell tumor, not related with the denosumab. Is basically driven by another mutation, so no longer dependent on the mutated stromal cells, so denosumab won't be working on them. So the clue is failure of mineralization following denosumab treatment. So you know the tumor already transformed. So the tumor will transform in. How we know it's already transformed? You've got sheets of atypical cells with atypical mitosis. Also to inform, typical mitosis, necrosis, and scattered atypical cell can be seen in normal giant cell tumor, conventional giant cell tumor, but it should be scattered, shouldn't be in sheet form. Okay, this is the additional driver. Okay, malignant giant cell tumor is divided into conventional type, non-conventional type, undifferentiated type. And also there's a term called de-differentiated type. It's just basically saying that there's a sharp demarcation between the conventional one and the malignant one. So it's called de-differentiated giant cell tumor. Basically, it's actually conventional malignant giant cell tumor. The non-conventional is when the giant cell tumor, malignant giant cell tumor morphology mimicking osteosarcomatous-like or fibrosarcomatous-like. The undifferentiated type will be like UPS. Okay, second case. It's a 42-year-old knee lesion. I think this one you see from far, you can guess already. This is the lesion in the knee, villiform changes and also cleft-like formation, and the cleft, some of the cleft are lined by these cells. From this low bow view, it's difficult to see the giant cell, but it's okay. Okay, higher power view, you can see giant cell and also the lesional cells, and you can appreciate the lesional cell is very different from the first one. They have a lot of cytoplasm. They are round, fat, the amphiphilic cytoplasm, and also they have rim of hemosiderin. And the background is macrophages. Yeah, this is giant cell tumor of tenosynovium and diffuse type. Okay, that one I will discuss later together with this case. Case number 4, 28-year-old lady with finger swelling. So the finger swelling, the morphology shows very nicely demarcated nodular lesion with a lot of giant cell, much more than the first one just now, the second case just now, easily seen. Composed of same cell, the round, fat, amphiphilic cells, with giant cell, a lot of giant cells, but you can appreciate here the giant cell have less nuclei than the bone type. Okay, this is tenosynovial tumor of localized type. Okay, tenosynovial giant cell tumor is a tumor involving synovium of joint, bursa, or also tendon sheath. It can be divided into localized, diffuse, or malignant type, which is rare. Usually occur in adult. Malignant type will usually occur in older age group. The localized type is usually in smaller joint or nearby the smaller joint. The diffuse type, I need to stand, I cannot see. Okay, the diffuse type are usually in larger joint, but also can be seen in extra-articular, such as in intramuscular or subcutaneous. The malignant type usually in relation to this diffuse type. Okay. Okay. Microscopy, the tumor contains mononuclear cells and multinuclear cells, same like the other giant cell rich stimulation, only that the mononuclear cells are of synoviocyte-like and also histocyte-like. Giant cell tumor of tenosynovium, the mononuclear cells can be easily differentiated between the histocytic-like and also the synovial-like, and also the accompanying osteoclast-like cells. Localized type will be lobulated. In diffuse type will be villiform, diffuse infiltration with cleft-like spaces. Chondrode metaplasia can be seen in tumor involving head and neck. and sarcomatous change can be seen in malignant type. Okay, the immunostain, you won't stain with G34W marker. You usually pick up CD68, and also the beta marker is clusterin. And in subset of cases, you can also see scattered desmin staining. Molecular wise, there's a new finding in the giant cell tumor of tenosynovium, which is the demonstration of CSF1 gene rearrangement in the lesional cell. This is chrome-ish. The lesional cell is much less than the non-lesional cell, which is stained with CSF1R. So actually, the rest of the cell are non-neoplastic cell recruited by the neoplastic cell positive for CSF1. So this is the same thing, just demonstration using fluorescent-ish. So the current treatment, because of the identification of this mutation, some of the diffuse giant cell tumor, non-operable diffuse giant cell tumor are offered with treatment with targeted therapy with tyrosine inhibitor, like such as imatinib. The latest one is the pexidartinib, but I don't think so we have here. Okay, another issue about giant cell tumor of tenosynovium. Too late, is it? Sorry. Yamita, anything?
Yeah. No, I'm just answering the questions in chat.
Oh, okay, okay.
But to be
okay. Okay. Another issue about giant cell tumor of tenosynovium, other than the malignant type, even the benign type can metastasize. So this article actually I explained how this can happen. According to them, it's actually it's more of a passive way rather than active vascular involvement, vascular invasion, and appear to be same pathway with giant cell tumor of bone, but conventional benign giant cell, not benign, conventional giant cell tumor of bone, chondroblastoma, and uterine leiomyoma. All these tumors are not malignant, but they also can metastasize. Okay, about malignant malignant tenosynovial giant cell tumor, when they transform, usually they will take the form of myxofibrosarcoma, fibrosarcoma, or undifferentiated pleomorphic sarcoma. Same like other tumors. Okay, case 5. Giant cell tumor of soft tissue. This one, I actually don't have a case. I haven't seen a case. So I'll just show you a picture from literature. So it's an intermediate group of tumor, have very wide range of each group, and usually occur in soft tissue of extremities, and also can be seen in other sites. Morphologically, is well circumscribed multinodular cellular lesion composed of with fibrous septae, composed of same thing, mononuclear cell and multinuclear cell. But the mononuclear cells are different because they are not like synovial sac. They are more like histiocytic-like. And also they can have all the changes like other tumors like hemorrhage, regressive changes, metaplastic bone, especially when metaplastic bone, and also the accompanying ABC changes. And also they can have mitosis and vascular invasion, but they are not malignant. IC is not useful because basically they are not, so because if I'm not mistaken, there's no molecular alteration identified in this tumor, so there's no specific IEC for it. So this is the morphology from literature. It's well circumscribed with occasional shell of bone, and the content is about the same on multinuclear cell and mononuclear cell, but you can appreciate the mononuclear cell is different. It's histiocytic-like, and it won't pick up with G34W marker. You sometimes will pick up SMA and CD68, and also occasionally SETB2 if there is bone formation. So in a subset of tumor in soft tissue giant cell tumor, they identified this mutation HMGA2 and NCOR2. which is keratin positive. But this is a different subset and shows different kind of staining pattern. So it might not be same subgroup of soft tissue giant cell tumor, but it is a new mutation identified in soft tissue giant cell tumor like lesions. They will be CK positive, and rarely they usually are SETB2 negative. And usually there is no bone formation in this kind of tumor. And also interestingly, the same mutation have been found in giant cell tumor of bone. This is different type. This is not the one with G34W mutation. Okay, case number 6. This is a mandible mass. I think when we say mandible, everyone already know the diagnosis. Giant cell rich lesion in mandible. Okay, as you can see the morphology. There's a lot of hemorrhage. There's giant cell, but it's clustered around the hemorrhage, and also the mononuclear cells. And if you can see the mononuclear cells, they are more like histiocytoid-like rather than synoviocyte-like. Okay. This is giant cell reparative, not tumor, reparative granuloma. Okay, it's often associated with trauma, mostly due to recurrent slow minor hemorrhage, and usually occur in young adults with slight female predilection. The tumor appear to be unique to jaw. In other side, we don't call it giant cell reparative granuloma, but we rather call it solid ABC because of the different type of mutation. In okay, never mind, the mutation I will explain later. So it's divided into localized type and also peripheral type. Sorry, it is divided into hold on for a while. Siap. Okay, central type and also peripheral type. Central type basically is intraosseous. Peripheral type is basically extraosseous. Okay, the extraosseous usually found in lower jaw and usually in form of polypoid lump ulcerating the gingival mucosa. But the morphology is the same. So both tumor will have non-capsulated cellular fibroangiomatous stroma with hemorrhage, hemocidin, inflammatory cell, and unevenly distributed cluster of small osteoclast-like cells. This unevenly cluster of small osteoclast-like giant cell is the clue that they are not giant cell tumor of the bone. So if you see unevenly distributed cluster of osteoclast giant cell in the jaw is giant cell reparative granuloma. If you see in the small bone, you can call it solid ABC. Okay, so we'll have frequent mitotic figures because it's a reactive kind of tumor, but there will be no necrosis, no atypical mitosis. The morphology is similar to brown tumors, but brown tumor will have a history of like hyperparathyroidism, such as because of end-stage renal failure, or rubism. I think that's how we pronounce it. So all these two tumors have similar morphology, but in different situations. This one is end-stage renal failure or other condition that can cause hyperparathyroidism. And rubism will usually in rubism is a congenital disorder and it involves all four jaw, causing a diffuse swelling of the jaw. Okay, molecular wise is there's few identified markers, which this marker is very important because it differentiates them between the solid ABC. So it like prove the giant cell granuloma is a different entity from the solid ABC. They are specific to the jaw. This mutation is similar to the one found in non-ossifying fibroma. So even though morphology about the same, but because of this mutation, we know they are different group. Okay, case number 7 is Okay, I think you can guess already because he's 68 years old with end-stage renal failure. And he has a tumor in distal femur. Okay, this is the morphology. You can see giant cells, but they are not really evenly distributed. They are somewhere here nearby the hemorrhage, and also the accompanying mononuclear cells are more like fibroblasts and histiocytes embedded in a fibrous stroma. Yeah, this is brown tumor related to the hyperparathyroidism. So usually it occurs in secondary hyperparathyroidism and rarely in severe primary hyperparathyroidism, particularly in chronic renal disease and also other diseases that can cause hyperparathyroidism. It involves any bone, but usually jaw. Basically, it's because of overactive osteoclast causing to microfracture and hemorrhage and subsequently formation of tumor-like lesion. So before the formation of tumor-like lesion, they can also be non-specific changes showing overactive osteoclastic activity. But once they form a tumor, then they become brown tumor. So adjacent to this brown tumor, you can see that the non-tumor area, you can see the same kind of morphology called osteitis fibrosa. And if this osteitis fibrosa form a cyst, then become osteitis fibrosa cystica. Adjacent, this is the one. Okay. What is the changes of osteitis fibrosa is the osteoclast, you can see eating up the bone, dissecting and tunneling into the cancellous bone. Okay, all right. This is the one. You can see the osteoclast is this one is actually, you can see adjacent to the brown tumor. The brown tumor already like forming a mass already, right? So usually difficult to see the native bone. So this adjacent to it, where you have native bone, the native bone is being eaten up by the osteoclast. And you can see here, they are eating up. Okay, just to show you the difference between Paget disease and osteitis fibrosa, the way they eat up the bone is like tunneling into the bone and surrounded by fibrosis. Whereas in Paget disease, it doesn't tunnel, it just burrow into the bone, and you can see the reversal signs. Okay, next case number 8. So we have two more. 17-year-old male with distal tibia lesion. Okay, this one will also be a giant cell rich lesion. In the MRI, it shows fluid sign within the tumor. I think when we say fluid sign, everyone can guess what is it. This is not my picture. This is not from our center. Is from WHO. So morphologically, you can see a lot of blood-filled spaces, multinucleated giant cells, and also the mononuclear cells, and also some bone formation in a shell, like forming a shell. In a higher power view, you can see the bone. Some are the usual osteoid, some are blue bones. Here you can see blue bones. And here you can see the osteoclast like giant cell and the mononuclear cells, and also hemorrhagic areas. And also some of the spaces will show fibrous septa. Yes, this is aneurysmal bone cyst. So it's a benign neoplasm showing multiloculated blood-filled spaces, mostly in first decade of life, no sex predilection. Usually occur in metaphysis of long bone, occasionally in head and neck involving the mandible, and also sometimes in posterior element of vertebra, rarely in soft tissue. There's two types, the usual ABC, and also the other one is a solid variant, and also ABC-like changes as a secondary change in other tumors. So in the usual ABC, primary usual ABC. It will be a multi-locular cystic blood-filled spaces separated by fibrous septa containing blunt fibroblasts of moderate celerity interspersed with osteoclastic giant cell, osteoblast ring osteoid, or delicate eggshell-like metablastic bone with occasional basophilic blue bone. I think this is the same. Okay. This is the identification of USP6 that really help to differentiate between all these giant cell tumor. So basically, USP6 is identified in a in ABC, a giant cell rich lesion of ABC, and also in the solid type within the finger. So last time, finger giant cell tumor of the bone in our previous WHO already been removed, is now called solid ABC because of the identification of this USP6. So within the finger, no more giant cell tumor of the bone. Usually it's giant solid type ABC. And also they identified there is no USP6 in kinetic location. Maybe the mandible. So this is the one we say they have KRAS and also other mutation. This location, when we see giant cell rich lesion, we call it giant cell reparative melanoma. And also it's been expandingly seen in other tumor like nodular fasciitis, myositis ossificans, fibrous pseudotumor of the digit, and also cellular type tendon sheath fibroma. So actually it's easy. If giant cell rich lesion, there's 3 types. One related with USP6, one related with G34W, one related with the KRAS and NF1. So it's easier to classify them now. Okay, case number 9, second last case, 14-year-old boy with distal tibia swelling. Okay, radiologically, this is from WHO. You can see it's a cortical lesion. I think this is very typical of that lesion. Once you see this, usually they won't send for sampling, I think, because it's very typical. Have narrow zone of transformation with sclerotic edge and also radiolucent within the cortex and in the metaphysis. So this is the morphology. It's more of like the fibroblast in a storiform pattern and very small giant osteoclastic giant cell and scattered, not evenly distributed. This is the fibroblastic-like morphology. Vesicular nuclei, more reactive looking with pinpoint nucleoli. It can have hemocyl-related macrophages and also foamy macrophages. Yes, this is non-ossifying fibroma. Everyone guessed it already. So introduction, but it's a benign tumor, also known with many other names. Usually occur in skeletally immature, but if you see the same morphology in a mature skeletal, you have to give another name. Maybe you can call it regenerative giant cell tumor of the bone, but you cannot call it benign fibrohistiocytoma anymore because it's already been removed in our new WHO. Benign fibrohistiocytoma is considered as same tumor with regressive giant cell tumor of the bone. So you can use the markers to help you to differentiate which one is which. Location-wise, usually occur in metaphysis of long bone within the cortex, and you can see the lesion is usually eccentric. Morphologically, it composed of blunt spindle cell in storiform pattern and scattered osteoclastic cells, and they are usually clustered together, not evenly distributed. See here, don't have, you got a lot. And then mixed with foamy macrophages and also hemocyl-related macrophages. Sometimes can form cysts. Okay, I just want to show you, want to share with you. This is cases from, I don't know, I forgot already. So these are also have similar name, ossifying fibroma, but it's not non-ossifying fibroma. It's ossifying fibroma. This is Samomated type, trabeculate type. This is cementum type. They are all usually in the mandible to make it more complicated. Okay, this is the one I was talking about just now, KRAS, FGFR1 and NF1 mutation. found in non-ossifying fibroma, making them different from other tumors with rich in giant cells. Final case. Case 10. 16-year-old male with calcaneal mass. Usually when we say calcaneal, I think everyone can guess already the diagnosis. Okay, this is the lesion. There is a well-defined epiphyseal lesion with sclerotic margin. Sclerotic margin, narrow zone of transition is all the word usually radiologists will use to describe benign lesion. So this is the morphology. Composed, at one look you can see, wow, very red, and then got a lot of giant cells. But the mononuclear cell is different from the other tumors. They are all the same. They are not mixture with macrophages. In the focal area, you can see this island, pinkish island. Can guess what is it? This is higher power view. You can see grooving here. They are some are obviously polygonal, some are not so polygonal, because this tumor usually associated with a lot of degenerative nuclei. So the better area will be polygonal with grooving. Yeah, this is chondroblastoma. Everyone gets correct. Introduction: benign tumor. They are benign tumor of the bone. Last time was labeled under intermediate type, but now no longer is labeled as benign because they found out that the metastasizing type is very, very rare. So they remove it from the intermediate group, they put it in benign group. So it can occur in any age, but usually in younger, in 10 to 25 years old. Usually occur in epiphyseal or subchondral region because they are composed of chondroblastic cells and also other location. But they will very rarely, almost never in craniofacial. Okay, so this is the morphology. They are composed of sheets of polygonal cells, very red, very eosinophilic, got groove. Okay. And usually you can see distinct cell border, but it's difficult to appreciate. And they are associated with a lot of degenerative cells. The one already degenerated, a bit already old a bit, they will have pericellular calcification, giving rise to the chicken wire appearance. But not necessarily you'll see that. Sometimes you can highlight it with reticulin stain. This is the island of cartilage, but something special about this cartilage, they are pink rather than blue. They also can have ABC changes, sometimes can have mitosis, sometimes can have nuclear atypia, but have to tally with the radiology. Bone tumor always have to tally with the radiology. Okay, this tumor also have new finding, the finding of the molecular marker, other molecular mutation, which is the H3.3G, the H3.3 K36M. This one. Okay. It also shows very high specificity and sensitivity towards the immunostain related to this protein. This is the K36M. This slide is from NUH. The staining is diffuse and nice. Sometimes a bit reduced in degenerated cells, but you can still see it. And they will not pick up the giant cells. So this is about the metastasizing chondroblastoma, which is considered very, very rare by WHO and being removed as intermediate group. But there is still cases of metastasizing chondroblastoma. For example, from this case, 54 years old with metastasizing chondroblastoma. He developed a lot of systemic metastasis, and his tumor showed the K34-6M staining, confirming the diagnosis. So it is a confirmed case of metastasizing benign chondroblastoma. So it cannot be forgotten. You still have to keep in mind and have to follow up about this entity. And also there's some discussion about chondroblastoma having a malignant subgroup because of the metastasizing chondroblastoma subtype, and also because of the chondroblastoma-like osteosarcoma morphology having K34M staining. So these are among the discussion about chondroblastoma, just to be aware of, so that can advise for longer follow-up. So that's the end of my lecture. I would like to thank my supervisors, Dr. Noorjehan from HKL, for sharing a lot of knowledge and cases, Prof. Victor sharing a lot of knowledge and cases and images, Yavita sharing knowledge, Afif also sharing knowledge and images. Thank you very much. And also to all my seniors and teachers in Serdang, Kelang, and also UPN. I have their images, but I hide it because this is a recorded meeting. Okay, that's all. Thank you.
Thank you, Jehan. I
What's
think
the
we
time?
need a better
Wow, 4 more
picture.
minutes.
I think we need a better
What? It's breaking up.
picture. Can you hear me?
Breaking up a bit, but can hear.
Okay, no, I think we need a better picture of both of us together.
Actually, I cannot hear Yamita a bit, but still breaking up.
Okay, never mind.
Okay,
Thank you very
right.
much. Yep. Anyone has any other questions? So far, we had one question about frozen section. So I think Dr. Noorjehan have said section.
Yamita, I stop sharing first. Okay. I'm trying to enlarge the stop share. Okay. All right. Okay. All right. Okay.
Okay. All right.
Okay.
So we had one question. It's about whether we can do frozen section for bone specimens. So I think Dr. Noorjehan, Afif, and me, we have already answered in the chat that it is not.
Okay.
We generally don't do. We can do for the soft tissue part or soft tissue lesions, same sections. Any other questions from the floor? If not, then we can continue enjoying our Saturday.
Yabi?
Yes,
Dr. Yabi?
Dr.
Okay, can just give a few words. Okay,
Yes.
thank you, Jehan. Very good presentation. I also learned from your presentation today. So for information that denosumab has been used as treatment of DCT in Malaysia for quite a long time ago, and I think I encountered quite a few numbers of denosumab treated specimens. Yeah, the only worrying part is that sometimes if you do Jasmine staining, these denosumab treated lesions may show positivity. So be careful not to diagnose this as as rhabdomyosarcoma. So always go back to the clinical history, the radiology findings. Always go back to this. Yeah. Okay. And secondly, I think the question about frozen, I also not comfortable to do frozen section for bone lesions. Sometimes because of this non-inflammatory, non-tumor component as well is present. So usually I would tell them, see if you want the margin, maybe I could help. If you want to know whether you have reached the tumor area, okay. But to know what is a tumor by itself on the frozen section, sometimes very difficult. So if sometimes they proceed, but most of them is for the soft tissue margin of the tumor rather than the bone part. Do not accept the bone itself for frozen section, because you won't able to cut it in frozen section. That's all, Yabi.
Yabi cannot hear.
Yes, Yavita, we cannot hear you, Yavita.
Unmute.
Dengar tak?
Dengar.
Dah dengar.
So thank you very much, Dr. Noorjehan. I think we don't have a question.
Yep.
Share Jehan's lecture. a brilliant lecture, Jehan. Very much. Thank you very much.
Welcome.
And I'll sign off now.
Okay, thank you,
Sarah?
Evita. Bye-bye, everyone.
Alright.
Assalamualaikum.
Thank
Thank
you.
you,
Everyone.
Danny.
Recording
Hafiz.
for this and the previous session nanti. I do have some at the moment some difficulty in terms of technical difficulties. So it will take some time because I have some security issue with the account. So I have this is why I tak upload lagi. But I try to get it done by today or tomorrow. Right. For starting next month, we have another session series. We are already arranging some speakers. Stay tuned. Just look at the website maybe by mid of this August because kita bagi Saito kat UiTM tu dulu settle, then we'll do our IAPMD punya registration for the next one starting from September. And of course, apart from that, what else? We are trying to expand. So maybe after this, our participation is more than 100 lah. And we'll do a dual platform rather than one. And thank you very much. See you in September with pediatric pathology by Prof. Tan. All right, bye.
Take care. Bye-bye.
Bye, Evita. Thank you. Bye.
Bye, everybody.